Me a person. Hola, bye. Eric, ke tsena webineng yo ke founela ke. Good evening. It's exactly 7 o'clock. Is everybody here with me? That means if you are not muted, just raise your hand to so that I'm audible. If anybody can raise his hand like this, I can know that I'm audible. Am I audible? Sure. Today, ladies and gentlemen, the webinar is on male infertility. The fact that it's male infertility, it doesn't mean it only affects male. It affects both males and females. Let me try if I can mute everybody, because I should be able to mute you all. I should be able to mute you all. I didn't allow you to unmute yourselves, but some people are not muted. I don't know why, but on my side, you should be muted. It affects both males and females, this male infertility, because it affects the family. My name is Dr. D T Mahapa. I'm here in Polokwane as a urogynecologist, and I greet you all and welcome you to this webinar. This webinar today, because it's about males, me being a gynecologist, I deal very little with women, with men. So I called two specialties that deals mostly with men. Those are Dr. Evelyn Moshokwa, which I haven't been able to contact her yet, and Dr. Munari. As we are here, I'll try to contact them so that they can zoom in. Their value in here is try to answer as many questions as you are going to answer, as you are going to ask, because alone as a gynecologist, I may not be able to answer all the questions that you are going to ask me, because I deal very little with men, but I do deal with them, but not as much as urologists deal with. I've got two urologists here, Dr. Monare and Dr. Mushukwa. They will be the one that will be answering a lot of questions, and I'll give them chance at the end to comment. And but I haven't been able to contact them. But during the week, I talked to them. They all both agreed that they will be here with me during the seminar to help me to unravel this problem of male infertility. So I hope they will join in due course. I tried to phone them this afternoon. None of them was there was not answering my call. I've been now trying to contact them, but nonetheless, if I can't find them, I'll have to deal with it alone. But in any way, in the meantime, as you are listening to this song, I will try to contact them. I'm trying to contact them. I couldn't find our urologist, but in any way, maybe they'll come. If they don't come, we'll deal with it. It was Dr. Mushokwa, who is a urologist in Gauteng, and Dr. Monare, who is a urologist here in Polokwane. At the end of my presentation, I'll give them a chance just to comment, and they will interact with you greatly with the questions that you are going to have. What is male infertility? What is infertility actually under general? Infertility is defined as inability of a couple to have pregnancy after 12 months of unprotected and frequent intercourse. What do you mean when you say unprotected intercourse? It means intercourse without any contraception. And when we say, what do you mean when you say frequent intercourse? We mean intercourse which is at least 2 or 3 times a week. Let me look for somebody who's not muted here, please. Try to mute yourselves, because on my side, I've muted you, but somebody has got the ability to unmute yourself, that side. Technology is very complicated. I can't control you, but just control yourself, because you are disturbing others. When we say that intercourse is frequent enough in a couple, should be at least 2 to 3 times a week. Infertility, by definition, is a couple's disease. There's a notion out there that infertility is a woman's disease. When the couple doesn't have a baby, they say the wife doesn't make children, as if the wife alone can make children. It takes 2 to tango. Infertility, by definition, is a couple disease, and it can be defined as follows. Couple might have primary infertility, which means they have never had a pregnancy. No pregnancy in a woman, or even a man has never had a pregnancy, or can have secondary infertility. That secondary infertility is in a couple who has had 1 or more pregnancy before, and now they are struggling to get a pregnancy. In general, about 15% or more of the couples are infertile, which means they are unable to achieve pregnancy after 1 year of unprotected and unrestricted intercourse. It is estimated that the male contribute about 40% of that infertility in a population, which means in a population about 40% of males, of infertile people, 40% of that infertility is contributed by a male factor, and the other 40% is contributed by female factor, which means both male and female factors have got equal contribution in infertility. If only 10% of the population find that infertility is in both male and female, so the population, while 10% of infertility in a population are said to be unexplained, which means, in summary, what I've said, that causes of infertility in men and women have equal contribution. So if the couple has got infertility, both men and women need to be seen, because they contribute equally to this infertility. Which means, which I have just said in the previous slide, I've just said that there is as much cause of infertility in men as it is in women. Both men and women should be investigated to get what causes infertility. If somebody the couple is infertility, both husband and wife should go and consult, and so that the cause of infertility can be found. As I said, 40% is likely to be in a man, 40% is likely to be in a woman, 10% in both, and only 10% will be unexplained. There are some people who are infertile, but you can't explain why they are infertile. Infertility itself is a multidisciplinary field. It doesn't need one field. It needs a gynecologist, it needs a urologist, it needs an andrologist, and all other allied specialties come together. So if you are on treatment for infertility, You mustn't be one that will be sent to from one doctor to another doctor, because only one doctor, not one doctor can deal with all the problems of infertility. Some will need a urologist, some need a gynecologist, some will need an andrologist, some will need pathologists. There are many specialties that must come together to treat the problem of infertility. So the cooperation of a couple in that way is very paramount, it's very important, because most couples, they lose temper on the way and stop investigation because they think they're being tossed from one doctor to another doctor, while actually that's how it must be done. Men traditionally, whether in any population, there's got this belief that the problem is always with the female if there is infertility in the life. And there must be sense into that. Men usually believe they are not infertile. This is just a pie chart to show that 40% of infertile couple is due to male factor, 40% female factor, 10% unexplained, and 10% is due to both. How common is this thing? About 20% of men in the population have said they've got infertility. But there's a way that when I said men has got a tendency of thinking that women are infertile, there is a sense what causes that. And this is what I think it causes that. Traditional science and African culture and beliefs and religious practices, they bypasses the true incidence on infertility. How do they do that? If there's infertility in the couple, the woman will make sure that the family grows. Somewhere, there will be a baby. So in that way, because there are always babies, even if there's male infertility, there are always babies in the family. People think that there are never a male infertility. There's no male infertility. A male can never be infertile because every married male has got the capability of having a baby in the family. But that is because the woman is the one who makes sure that there's a baby in the family. You as adults, you will decide now, how does a woman alone decide that there's a family there's a baby in the family while the husband is infertile? But it does happen. And in African culture, some people also say that it's only the mother who knows who the baby is. And in our culture, we've got many idioms that explain this. They say, all these idioms, what they mean to say, if you've got a woman that you sleep with and she falls pregnant, that pregnancy is yours until proven otherwise. You cannot blame somebody else to have impregnated the woman that you sleep with every night. If a woman is staying with a man and that woman falls pregnant, that pregnancy belongs to that man until proven otherwise. That's how Africans treat it. And most people treat it like that, because it will be childish to say your wife is pregnant by another man while staying with you in the same house. So in that way, the male infertility doesn't become more. Male infertility in itself does not translate into childlessness. So that's why people believe that a male is never infertile, because even if he's infertile, the family does grows. Infertility, some people have got what you call are infertile, but not totally infertile. They are subfertile. There are some people whose fertility is very low. They are called subfertile. The couple with decreased reproductive potential. They are not infertile. They can have a baby, but their ability to reproduce is lower. There's another term which can be confused with subfertilities, fecundability, which is the probability of achieving a pregnancy within one menstrual cycle. Some people who are very fertile, their fecundability is very high. Within one menstrual cycle, their probability of having pregnancy is very high, while others is low. While fecundity is the probability of achieving live birth within a cycle. Because when you go in, while I include fecundability here, because infertility also includes people who have repeated pregnancy losses, people with repeated miscarriages. They are also regarded as being infertile, although they don't fit into the definition of infertility, but they are seen at infertility clinic because they cannot carry pregnancy to term. What is the physiology of male infertility? In men, fertility requires a normal function and coordination of many physiological processes which are complex, which may result into production of sperms. This all happens in the testicles. Sperms are produced in the testicles, and the physiology that forms sperms is complex and intricate. We're not going to explain it here. And after sperms are formed, they must mature there in part of this testicle called epididymis, and they must be transported from there through the vas deferens, through the penis, and be deposited into the male genital. And when deposited, there must be an adequate amount of normal sperm, not all sperms, normal sperms. Abnormal sperms are not useful in fertility. The adequate amount of normal sperms must be deposited in the female genital at the right time, which means around ovulation. And there's only a window of about 4 to 5 days in a menstrual cycle that a woman is fertile. So that's why some people have got infertility, because the timing of intercourse they don't have sex during the time when the woman is ovulating. And the frequency of intercourse, I've said in the definition that it must be 2 to 3 times. The timing and frequency is very important when treating infertility. What is the pathophysiology of male infertility? Male infertility can result from the following: disorder of production of sperm. If production of sperm is not good, a male will be infertile. And that is due to usually deficiency of male hormones, which are called androgens, or inability to attain erection, whether it's a flexogenic erection or psychogenic erection. It might also be coital disorder, which might be too frequent coitus or too infrequent coitus, or disorder of sperm transport can be affected by 2 things, which we'll explain later. Is either the transporting tube, which is vas deferens, might be blocked somewhere, or it might not have cilia that transport them, or the sperm themselves might not be there, have the ability to move. We'll describe this. Or infertility can happen because there is no coitus, there's no sexual intercourse, because the man has got what you call erectile dysfunction. This erectile dysfunction is one of the commonest causes of infertility. And if it's there, it's visible, and the woman will see it because they cannot penetrate. And that's why we have got men's clinic. Men's clinic usually deals mostly with erectile dysfunction. Erectile dysfunction can cause infertility because sperms may not be produced without an erect penis. And that, if it's erectile dysfunction, you might have disorder of ejaculation, although the disorders of ejaculation can occur in other conditions, which we'll describe later. What do you mean by coital disorders? I want to say that too frequent sex every day, is a sex disorder, is a coital disorder, because it reduces the number and the quality of sperm that are produced there if sex is every day. And too infrequent sex also is a disorder, because it increases the chance of having many old sperm, some of them dead, some of them not be able to move. And one of the coital disorder is premature withdrawal, poor timing of sex away from ovulation, and masturbation, and so on. There are a lot of coital disorders that a man can have, which should be asked about, because some men are infertile because they masturbate a lot. And in some men and women, there are some antibodies which are called anti-sperm antibodies. These anti-sperm antibodies, they kill the sperms. Once the sperm come, they kill them because they fight the sperm. So you find that the sperm are not alive because either the man himself has got anti-sperm antibodies because of exposure to the semen from previous injuries, or the woman herself has got anti-sperm antibodies that kill the husband's sperms. Both must be investigated and find if they are treatable. In South Africa, we have a growing concern, mostly among Africans, that infertility is rising. South Africa faces a hidden fertility struggle. majority of our youth in the reproductive age are infertile. Besides the fact that there's a booming population rise and increased teen pregnancy, there is a lot of proportion of infertile male out there. And the decline in infertility, fertility rate going down, and majority of number of couples that are desperate about becoming pregnant are high in South Africa. So infertility is on the rise in South Africa, mostly because of male infertility, although female infertility does contribute, but there's a rise in male infertility. So male infertility remains hidden behind female infertility, as I've said before, that the females will devise means to overcome the deleterious effect of female infertility. Although there's a rising use and teen promiscuity and moral degeneration, we can accept that our teens and youth are more promiscuous than ever before. Diseases like gonorrhea, sexual transmitted infection, chlamydia are on the rise. And those diseases themselves, they cause infertility. They cause testicular damage, they cause strictures, they cause epididymal damage, they cause infertility in a male. Another common cause of infertility, which is so common now, in every village is there, is alcohol. Alcohol is becoming now the leading cause of male infertility because what does alcohol do? Alcohol reduces androgen production and it causes impotence. It's worse when if mixed with marijuana. And our youth now, they mix alcohol with marijuana. We are told that marijuana is now legalized. And it always wonders me now, why did people legalize marijuana? They think the medicinal effect of marijuana that they claim are there are more than the toxic effect of marijuana on the body, even on the mind, because it also causes madness, it causes infertility, it causes impotence, it reduces sex drive, it's got effect on the testicular function and the function of androgen, it reduces sperm production, people have got less sperms, abnormal sperm. Marijuana is very dangerous on a man who is fertile. And one thing about marijuana, which on the population you observe, because it reduces androgens, marijuana people are never womanizers. They don't want a woman, they just want their marijuana. So our youth are now into marijuana and alcohol. And if you go to any village, it doesn't matter urban or rural, the only business that a man, an African man does is a tavern. When a man wakes up in the morning, before he can even have breakfast, you see big men like this one. They go to the tavern, they go and chill there. They say they're chilling. In any village, there's no village without a tavern. That's the only business that an African has invented and is mastering. If you go to pass any tavern early in the morning before the tavern open, you'll find youth waiting there, waiting for them to open. That's their breakfast. Breakfast of the youth this day is alcohol. They drink alcohol. In the midst of this poverty, you'll find youth waiting outside the tavern, waiting for alcohol. It's not uncommon to find an African youth destitute and poor, even without shoes, without clothes, without food, but he can afford an alcohol. It's no more even a taboo to move in the village and found a young boy moving in the street having a bottle of beer. Is a prestige. You know, when we grow this beer, which I was for, blacks were not allowed to drink it. And I think that was a good thing. You know, there are good things that happened in apartheid. I don't know why they allowed black people to drink hot stuff and other things, because now they're drinking more than even the makers of hot stuff. One of the good things that was happened during that government when they didn't allow black people to drink this, I think it was good. I think they must come back. Let's look at the functions of the testis. The function of the testis is to produce sperm. And every 72 days, sperm is formed. Unlike an egg, every woman is born with a certain number of eggs. If you are 50 years old, your eggs are 50 years old. But sperms, every 72 days, new sperms are formed. They are produced in part of the testicles, which is called seminiferous tubules. During embryology, there are about 30,000 spermatogonia cells, germ cells of sperm, where sperms come. There are about 30,000. But these spermatogonia undergo the process called mitosis, cell division. So it's that by about 9-10 years of puberty, there are about 6 million. Pardon me, our urologist is phoning. Dr. Manara, are you joining? Are you joining, my friend?
Am I joining?
Joining the webinar. At the end of the webinar, we'll need your comment.
Oh, all right. I should. Yes, I should.
Just log in.
Yes, but I'm going to be doing it driving, yes.
Yeah, but you'll hear me. I'll give you a chance to comment thereafter. I'm on slide number 12. I've got 42 slides. I'm on slide number 12. You'll catch me. Ladies and gentlemen, Dr. Manari, I found him. I didn't find Dr. Bushuka, but Dr. Manari, I found him. He'll join. Sure, bye. I was saying that was our urologist. This spermatogonia, by cell division, they produce about 6 million. By the time of 600 million. By the time you are puberty, they are in each test is about 600 million. By the time you are an adult, there is about 200 million sperms per ejaculate. One ejaculate produces 100 to 200 million. And this is because of the hormone, which is a male hormone called testosterone, which is produced by the cells in the testicles, which are called latex cells, together with follicle stimulating hormone. In that intricate process, they form sperms. And to explain it simply, one spermatogonia cell will divide by the process called meiosis. There are two meiotic divisions, meiosis 1 and meiosis 2. And they divide by meiosis to form spermatocytes. As spermatocytes, by the second meiosis, they divided to form another spermatocyte. The first spermatocyte is called primary spermatocyte, and the second generation of spermatocyte is called secondary spermatocytes, which undergo mitotic division to spermatids. These spermatids are the final product which mature and metamorphose into form spermatozoa, which are sperms, as we call them. And all this happen in part of the body which is called a testis. This part of the body has got a portion which is called seminiferous tubules, many seminiferous tubules where the sperms are formed, which coalesce here in a part of the testis which is called rete testis and form an epididymis, which has got the head, the body, and the tail. From the epididymis, then there's a duct tube that sperms can travel through, which is called vas deferens. We'll see that later as we go. We're not going into detail now. And this is just a simplified schematic presentation of the pathophysiology of sperm formation. In the brain, in the hypothalamus, there are hormones that are called gonadotropin releasing hormone that acts on the anterior pituitary gland to produce the gonadotropin, which is LH and FSH, which acts on the testis, and the testis produce sperms. If it's a female, they'll act on the ovaries. And this will happening in the testis will give a final product, which is a sperm. The maturation of sperms here take place in this part, the head of the epididymis, and that are transported through the vas deferens to the outside, to the urethra during ejaculation. Let's see this. This might give you a little bit of clue. This is a brief explanation of what how sperms are formed. What is the physiology of sperms after ejaculation? There's a process that takes place even after ejaculation that makes a man able to fertilize. The sperm must undergo the process called liquefaction. Normally, if you look at the sperms, they are not, they are viscid, they are gel-like. They must undergo liquefaction. Let me remove this person. They must undergo liquefaction for you to be able to fertilize a woman. The liquefaction occurs by the process of the enzyme activity that is found in the prostate, which causes the sperms to be liquid. It's the process of liquefaction. I'll just demonstrate to you liquefaction later. And there's also a process that happens after ejaculation, which is called capacitation, which is a biochemical process occurring inside the female genital reproductive tract when the sperm is deposited there, which enables sperm to fertilize an ovum, which means the fertilization potential of a sperm, it also needs an environment conducive for capacitation in a woman. That's why I said a woman who has got anti-sperm antibodies, the husband will never be able to fertilize that woman because the woman has got anti-sperm antibodies. Thereafter, there's what you call acrosomal reaction. The sperm on the head has got a head which is called acrosome. Acrosomal reaction itself, it means that the reaction that occurs after the sperm is capacitated by influx of transmembrane influx of calcium and other elements, and it plays an essential role by making the spermatozoa able to penetrate an egg. Without acrosomal reaction, the sperm might not be able to penetrate an egg. Looking here, if sperm come around the egg, they must have capacitated. For them to penetrate this egg, there must be a reaction, which is acrosomal reaction, to be able to digest this layer that surrounds the egg, which is so hard, it cannot be without acrosomal reaction. It cannot be. This explains me more than I can explain it. This is exactly briefly how you can understand fertilization. It's how you understand a sperm. This is the anatomy of a sperm. It's got a head, which is tapered head. It's got pinhead. It's got a middle piece and a tail. And I said it produced in the seminiferous tubules of the testicles. It's shown easily here. You can see there's a head. This cap that is here, that is what we call acrosome. The acrosomal reaction depends on the acrosome, such that it makes the sperm, it enables the sperm to penetrate an egg. Causes of male infertility can be, this is not exhaustive. The list is not exhaustive. It's just few that I mentioned here. There are many other causes that I didn't mention here. There are causes in the hypothalamic pituitary disorders, in the higher center, in the brain and the pituitary gland, which one of them is called idiopathic isolated gonadotrophin deficiency. Gonadotrophin, if they are deficient, they are not there, which are the hormones that make the gonads to produce gametes. If there is, say, it's said to be idiopathic, when something is said to be idiopathic, which means we don't know what causes it. When the disease is idiopathic, means we don't know what caused that disease. It's just like that. You find that a person has got deficiency in gonadotrophin, but you don't know what causes it. And then there are other conditions, which is called Kallmann syndrome, which I'll explain later, which causes infertility. A man looks normal, but he's got Kallmann syndrome. Some people have got pituitary tumors of the pituitary glands, which interferes with production of the gonadotrophins, such that gonadotrophins are those hormones that act on the gonads. They are from the pituitary. And diseases like meningitis in childhood can also affect sperm production later. And the pituitary tumors usually produce hormones called prolactin. Hence, you have got what we call prolactinemia. Such men will find that when they express their breast, there's some milk discharge from the breast because of this prolactin is a hormone that is responsible for milk production in female. And some women, men who they look nearly normal, but if you know what a Klinefelter syndrome is, you can see that this man might be having triumphant. What I want to emphasize is infections. Infections, commonly mumps. Mumps in our mother tongue, mauwe. Even the grandmothers at home, they know that mauwe, if mauwe can have a child after puberty, chances are that that baby child, that boy child, will not be able to fertilize a woman in future. That's why if your mother-in-law knows that your husband has had mumps after 9 years, he will tip you to say, hey, you must make some means that this family grow. This man will never fertilize you. Mumps must not be treated lightly if it affects a child after 9 years. Mumps at infancy is not a problem. After puberty, when there's already gonadotrophin and sperm formation is high, that's that mumps affect the testicles and cause what we call mumps orchitis. And mumps orchitis in itself will affect sperm production. Is the commonest cause of acquired primary testicular failure. If testicles fail from the acquired cause, one of the causes we ask, didn't you have mumps when you were already old? It starts first by having a pain and swelling of the testicles. And 1 in 4 males who have got mumps will be infertile. Not everybody who has got mumps will be infertile, but 1 in 4, quarter of men will be infertile. And mumps, I must say that infertility, male infertility caused by mumps is irreversible. You cannot reverse it. It causes azoospermia. That person doesn't produce sperms. The inflammation and pain in the testes, which is followed by edema and swelling. After remission, there is a drying and sclerosis of the seminiferous tubules, that area where I said the sperms are formed, and hyalinization, they become dry. And months or years later, one can observe that the size of the testicle becomes smaller. It's got testicular atrophy. They've got small testicles. So infertility from mumps is very irreversible. And usually mumps affect the parotid glands. You find that the chins are swollen. But if it causes pain and swelling in the testes, it's bad luck. It causes testicular failure, irreversible. But it's not the only infection that causes testicular failure. TB, ordinary tuberculosis, and leprosy can also cause testicular failure. But these are treatable and irreversible epididymal orchitis. It's the same as epididymal orchitis caused by gonorrhea and chlamydia, which are sexually transmitted infection. They are treatable if seen very early. They also cause seminiferous tubulars damage and cause low sperm count, mostly like gonorrhea. That's why I said with the increased promiscuity in the youth, the rate of gonorrhea is very high. So majority of youth will end up with male infertility. And I want to stress that youth mixed with STI, alcohol, marijuana it just reduces sex drive. It causes impotence. So we know that in 2018, the Constitutional Court of South Africa ruled that a person may be in possession of cannabis or marijuana in private for his or personal consumption. And that's a bad ruling. And it was done by the Chief Justice. John is the one who came with this thing. I don't know, he doesn't know what the effect, or does he know the effect of dagga on other body parts? The use includes smoking, cannabis. It only say you mustn't smoke it in public, but you say you can smoke it. I think that way he was advised that we must make this infertile because cannabis make our youth infertile. It causes a person is not even interested in women. It causes reduced androgen deficiency so that you don't even think about sex, no erection, erectile dysfunction, and the man has got no desire to have a woman next to her. Of course, some drugs also for treatment, if we undergo treatment for cancer, and anti-cancer treatment will also affect normal cells, which are dividing faster, like spermatogenesis is an area where cells are dividing faster. The cancer treatment will also affect from production of sperm, like environmental people who work in the heat. I'll come to the effect of heat later during the presentation. One of the commonest things that cause male infertility is because of heat. It's called varicocele. What are varicocele? If you look at the normal testis like this, it's got this epididymis. This is a normal testis. This is the testis which the red, which has got epididymoitis infection. If you've got infection there, there'll be a lot of, any infection is accompanied by pyrexia, heat. That's why if somebody is sick, you find that the temperature goes high because there's high bacterial division there. That heat here, if it's very high, it reduces sperm production. Because for sperm to be formed, they must be formed at a temperature far lower than the body temperature. That's why I'll explain to you later why it's like that. Before I explain to you, I want to explain these two conditions that are prevalent in the community. Undiagnosed, you don't know that this man is a Kalman syndrome or is a Klinefelter syndrome, but I can see a Klinefelter syndrome. But majority of people in the lay people, they won't recognize it. People with Klinefelter syndrome, they've got low sperm count or no sperms at all. But they look normal. They've got beards. They're male. They're gentlemen. They've got small testes and small penis, smaller than the average. And they've got low sex drive, but taller than average. They're tall people with low sex drive and small genitals. And their bones are very weak. They break very easily if they were in sport. And a normal man should develop beards. And a man who's well androgenized, who've got high testosterone level, will have beards on the chin and even on the chest and the abdomen. But this one will have very few female body hairs. And she will be less muscular than other men. And if we look at the breast, their breast will be slightly enlarged. It's called gynecomastia. This is the signs of a Klinefelter male. That man, if he in a couple with a man like that doesn't have a baby, chances are that the male is the one who is infertile. Unlike the man with Kalman syndrome, which they present usually with undescended testes. Undescended testes, I mean, the testes that failed to descend into the scrotum, they remain in the body. And while remaining in the body, they are exposed to the body temperature, which is about 37.2 degrees. They also have small genitals, and they've got facial. They can sometimes, not always, they'll have some facial dysmorphia like cleft palate and cleft lip. Not always, but sometimes. They've got a pathognomonic of them. They've got short fingers fingers of the hands are shorter than others, but they're not short-sighted that they're like Amelia. And majority of them was one kidney missing or one kidney abnormal. One is pathognomonic of them. As they grow, they develop hearing loss and color blindness, and they start having abnormal movement. This is a typical picture of a Klinefelter syndrome. He looks feminine. You look at the calves, the breast, but he's a man. He's got a male type of pubic hair distribution and small genitals there, big thighs like this. He looks feminine, but he's a man. He's genetically a man. He's 46XY. And more to see more pronounced, you'll find she's got an increased carrying ankle. If you look at where, if you put your hands on the side, on your side, there's an ankle there. It's got increased carrying ankle. This is called sorry, decubitus valgus. There's this the hands are turned out, and there's this varus deformity of the knee. The forearm are kicked away from the body. And if you look at their chest, they've got what's called pectus excavatum. The chest is, breastbone is sunken inside. Like a normal person, the breastbone is just flat here. The sternum is flat. The breastbone and the sternum is sunken inside in such a man. Such a man is likely to be infertile, and that's irreversible infertility. One of the causes is disorders of sperm transport. Obstruction of the epididymis, which is that pipe that takes the sperm from the testis to the vas deferens, to the penis. Or some people are just born with congenitally absent vas deferens. Infection like gonorrhea and TB, I've said, it can affect the vas deferens and cause stricture and cause blockage of the urethra and the vas deferens. For sperm to move inside, there are some hair-like process which is called cilia that propel the sperm forward. If you've got a condition called Cartagener's syndrome, those cilia are called lacy cilia. They don't prospect, cilia are hair. They don't propel the sperm forward, so sperm don't move. The other one condition is called Young syndrome. Young syndrome patient present with the clinical 3 conditions. She has got sinusitis, as well as she has got sinuses and bronchiectasis. And when she ejaculates, she has got no sperms coming. She has got obstructive azoospermia. There's obstruction of sperm production from the testes, either in the epididymis, near the prostate, or in the beginning of the urethra. Sperms don't come out, they are obstruction. Usually the obstruction is epididymis, near the junction of the head and the body. Since this condition, since obstruction usually occur after puberty, fertility is possible in some patients if the sperm can be taken from the testes, cryopreserved, and through assisted reproductive technologist, the couple can have a baby. But how many people can afford assisted reproductive technology? Because in vitro fertilization, the last time I checked, it was about 80,000 rand per cycle. How many people have got 80,000 rand? Some people with spinal cord diseases or injuries might have a problem with ejaculation. And there's also a condition called hypospadias, which I'll explain later, which causes abnormal ejaculation. Men these days, we're living in the era of gender equality. The couple come together and say, we are together in this. So since I did 4 scissors, it's time here that you, darling, we must sterilize. You must tell me the family is enough. I think it's time that somebody must sterilize. One of us must sterilize. But I think because I had 3 cesarean sections, you have never done. Even the men will volunteer and say, I will be the one who sterilizes. And life, you can't predict. Life changes. And she gets another partner. And she has done vasectomy. Vasectomy is tying of the vas deferens, which is a form of male sterilization, which is commonly done here by men. If such a man who has done vasectomy can remarry and want to have a child in the second marriage, he won't be able to produce sperm because you have tied the tubes. And more often you find that this information is not given to the new partner. The new partner is hoping that there will be a baby while the man has vasectomy. That's why when you treat male infertility, there are moments where you must bring them together and interview them. And there are moments where you must separate them to get the truth. Because there are some things that one partner cannot say in front of the other partner. This is a picture of one of the commonest causes that I found very common that is causing male infertility is penile pus-like discharge of gonorrhea, gonococcal infection. They used to call it drop. Some people call it chofela. It's got many names. This is a picture of showing you that I was describing. If a man has done vasectomy, this is the vast difference. They tie it here and cut it. So the sperm from the testis, instead of going through and come through the prostate and come out at the penis, they won't because you have tied them there. Let me show it again. It is tied. During vasectomy, they bring out the vas deferens and tie it and cut it. But this, theoretically, they say this is irreversible. Sorry. You can reverse it. But how many people have got microsurgical technique to can successfully reverse such a small thing? It's reversible, but success rate is very poor. So do not do vasectomy relying that you'll reverse it because it might fail after reversing it. I talked about heat as the cause of male infertility. There's a condition which is common among men, which is called varicocele, which is an enlargement of the veins within the scrotum. It may develop as a result of poorly functioning valves that are normally found in the veins. These varicocele, I can explain them like the varicose veins that you see on the legs. If you've got varicose vein inside the scrotum, it's called varicocele. It can occur from compression of these vessels, the veins, by other structures as they drain the testicles. They usually produce no symptoms. There's no pain, but can cause low sperm count or decrease sperm quality because they increase heat in the scrotum. The scrotum, the reason why scrotums are outside, we'll explain it later. This is a picture of a normal veins, which is called pampiniform plexus of veins, which drains the testicles. If they get, the valves becomes incompetent, they are like on the right, they get dilated like varicose veins on your legs and thighs. They get dilated, and as they dilate, they increase heat around them, more especially in the epididymis, where sperm maturation takes place. And in the milieu, in the area of high heat, that's where sperm quality becomes low. Another condition, which is common but not prevalently said, is what you call Peyronie's disease. Many men here have got Peyronie's disease. The condition in which there's a fibrous scar or fibrous tissue, scar tissue, deeper under the skin of the penis. It causes the penis to curve and it causes a painful erection. So a man avoids erection because erection becomes painful. And it can also make the penis shorter while it's erect and curved. A curved penis while it's erect is called Cody. I'll explain Cody later. So this is what Peyronie's disease do. There will be a fibrous scar or a fibrous plaque of the scar inside the skin here. During erection, the penis will curve and become painful, such that that couple will be infertile because a man will avoid erection and will avoid intercourse. So majority of people who come for infertility, ask them whether there is a process that they do that makes them have a baby, because some of them will avoid that process because it's painful. Nobody wants to have painful. People want to have sex for joy, not for pain. I said when a penis is curved, that condition is called Cody. Cody can happen from Peyronie's disease, from hyperplasia, from many conditions, few conditions. Cody is a condition in which the penis is bent or curved, usually downwards. It usually Cody is present at birth, and it might be accompanied by abnormal opening of the urethra, which is called hypospadia, where the urethral opening is not through at the tip of the penis. Usually, the urethra opens at the tip of the penis. You find that it opens either at the coronal sulcus or it opens on the shaft of the penis or underside of the penis. And this COD can vary in severity from mild to severe depending on the degree of whatever caused COD. You look at the normal penis, the urethra opens at the tip there at the glans penis. But if you've got hypospadias, it opens just below reaching the glans, it opens. Or sometimes it can just open at the junction of the penis and the testis. So during ejaculation, the semen will come out here, which is not inside. So ejaculation will be outside. And what you should examine for that, because you might find that a person doesn't have a sperm abnormality, but because ejaculation is outside because she has got hypospadia, which led to COD. This is the degree of COD I talked about. It might be mild, moderate, or severe. So, but the urologist can surgically, they can correct that. Very rarely, hypospadias when the urethra opens inferior. Sometimes urethra can open upwards, which is called epispadias. And these conditions, you can see them in childhood because these are congenital abnormalities. Even a small child, women at home will see that this woman, this boy child, the genitals are not normal. The urine is not coming out where it's supposed to come. Instead of the urine coming out at the tip of the penis, is coming out below or just before the glans penis or at the shaft, and they can observe that. But unfortunately, they can observe that, but the majority of them don't know that it's treatable. That's why I bring it here, so that should you have any baby like that, a newborn baby with hypospadias, is successfully treated while the baby is still very small. Don't allow it to be an adult. Some men has got what you call ejaculatory disorder. They've got one of the ejaculatory disorder is what you call premature ejaculation, which is ejaculation that occurs soon after penetration and later is followed by sudden loss of erection. 1 second once you enter, ejaculates, and then from there can never, he loses erection. And then if he loses erection, you know, a normal man, after ejaculation, there's a period which is called a period, transition period between which you cannot have another erection. That dead period, it differs as age goes by. It's called a refractory period. It's a period that you must regain again and start go through the sexual cycle. No man can ejaculate and ejaculate again and ejaculate. Unlike a woman can have multiple orgasms, one after the other. But a man has got a refractory period, which becomes longer as you age or becomes longer as you get more diseased. So another cause of male infertility is retarded ejaculation, which is ejaculatory disorder, which is described by inability to ejaculate irrespective of desire. You will have climax, but you won't ejaculate. It will be called dry sex. The sperms are there, but you won't ejaculate. Some people have got what you call retrograde ejaculation. Retrograde ejaculation, what it means, instead of the sperm as they pass through the prostate, going through the urethra into the penis, they go back into the urinary bladder and you ejaculate inside the urinary bladder. Such people, while you test it, after ejaculation, if you ask them to urinate and you look at their urine, it's darkish, it's grayish, it's like it's milky, gray and greenish. And under the microscope, if you test that urine under the microscope, you'll find that it's got spermatozoa. Retrograde ejaculation is caused by usually diseases like prostate surgery, where the sphincter that closes the bladder during ejaculation is incompetent and it allows the sperm to reverse back. Another people will have severely reduced semen volume from various causes, including testicular damage, including masturbation, including too frequent sex. I said that too frequent sex is dangerous. It doesn't allow the testis to form enough time to form the spermatozoa. This is a picture of retrograde ejaculation. If the sperm moves from the testis to here, instead of going through the penis here, it goes back into the bladder. This is retrograde ejaculation. The one that I have said, premature ejaculation also can be caused by many things. Most of them is psychological, like performance anxiety. Unresolved marital conflicts can make the man to have premature ejaculation or dry ejaculation or other emotional problem. Even tumors like spinal cord tumor and multiple sclerosis can cause that. So it's important that if there is some problems in the family, usually if the problem are caused by infertility itself, must be resolved quickly because they themselves might perpetuate the problem. We might just spiral the problem and find that one problem is in another one, and there's husbands start having performance anxiety, husbands start having retrograde ejaculation, start to have erectile dysfunction, all this. So anxiety and fear must be treated very clearly. And another cause of a dry sperm production, dry ejaculation, anxiety, fear of pregnancy. Most really, if sex is what you call extramarital sex, you fear that if this person can be pregnant, then there's a problem at home. Then that way you either have erectile dysfunction or you have dry ejaculation. Or if you've got religious conflict in you, you are a born-again child of God, suddenly you start to do things that you're not supposed to do, and your conscience tells you you shouldn't be doing. Immediately you lose erection. Immediately you have got dry ejaculation. You will not ejaculate. Of course, other things which in normal couples will be injury, as I've said, injury to the bladder sphincter, which is caused usually during surgery for the prostate, usually benign prostatic hypertrophy or prostatic cancer. Drugs and diseases also can cause that, and many things can cause a problem. Let's talk about, I said heat is very important on the testes, and I thought I should bring it here. There's a condition called cryptorchidism. Cryptorchidism, by definition, means a condition in which one or both testes fail to descend from the abdomen into the body. We know that human testes are usually in the outside. So if your child is born without descended testes, with undescended testes, that condition is cryptorchidism, and she won't be able to produce sperms because sperms need a temperature at least 5 to 8 degrees lower than body temperature. Body temperature is about 37.2. So you need about 25, 26, 28 degrees was normal sperm production. Some people have got testes that can retract inside the abdomen, retractile testes. And once they retract, they are exposed to that heat inside the body and cause poor sperm formation. Or testes that are undescended and are ectopic, which means are sitting in an abnormal site. They are under the femoral triangle or in the pubic area. I'll show you different areas where the testes can be if they are not descended. They can be in the abdomen. If a child is born without testes in the scrotum, those testes might be in the abdomen, might be in the inguinal canal, might be in the femoral, might be in the pre-prostate, they might be in the anterior to the pubis, might be somewhere here. So must be, the urologist must go and look for it and remove it to bring it outside before puberty so that the testes can be acclimatized to the temperature lower than body temperature and form sperms. Another cause of male infertility is lifestyle factors, obesity. You know, obese people have got big thighs and big everything, and heat there, the scrotum inside, the heat there. The testicular formation is very poor. Sperm formation is very poor by the testes. And one of the things which is in fashion now, the thing is fashion. Of course, it's fashion, but it's a deadly fashion. It's tight underwears. Men who put tight underwears, they put their genitals right against the body, and the testes are now functioning at a temperature of about 37.2, at a temperature of body temperature. And at body temperature, there's always low sperm count, low sperm formation. Of course, other habits like alcohol and smoking, they decrease the sperm count and motility, and they also cause erectile dysfunction. Occupation, some occupation expose people to toxins like mercury, which can also affect sperm motion and sperm count. You must never, ever, ever, if you are a man, you are using with a laptop, you think you are learned because you are working with a computer with a laptop, put your laptop on your lap. The type of radiation, that electronics that goes there inside the laptop is not good for seminiferous tubule function. Most people who work on their way to work, you find that the man is working, is putting a laptop on his thighs. I always warn them and say, my friend, we are injuring a very important fact. That laptop is not good. It's been shown. Even cell phone in the pocket, if it keep on ringing in the pocket, if it's closer to the pocket is anterior, it's got a deleterious effect on the testicular function. You better put your cell phone on the chest. Of course, we know that drugs like marijuana and others, they cause erectile dysfunction. There are many causes. Look at these two types of gametes. Which one you think is a fertile man's gamete? These underwears. These on the right are the ones that are very bad. And they're actually made of material which is very, it heats very wide, which is very warm. And you take the testes and put right against the body temperature. If it's right against the body temperature, which means testicular formation, sperm formation is happening at body temperature. And that's where you're going to have low sperm motility, low sperm count. Unlike a man who has got a well-ventilated genital, testes are far away from the body temperature, about 4 or 5 degrees below, then that man is likely not to have deranged testicular function. Take, for example, a bull. Have you seen a bull with the testicle inside there? And a bull like this one, you know that is a good bull. It will make a crawl grows. So the same man works like a bull. The reason why the testicles are outside is because spermatogenesis, sperm formation, must happen at a temperature far lower than the body temperature. It mustn't be there. So don't put them against the body temperature thinking that is fashion, you're fashionable. Of course, you'll be fashionable, but infertility will be fashionable. Another contemporary causes, which is lifestyle factor, is people who are well paid, people who are, they drive expensive cars, but they never impregnate anybody. They're womanizers, but they never impregnate anybody. The people who have cars that have, they tell the people that my car can hit, I can hit my seat of a car. I just press a button, the seat of my car can hit. If you've got a heated car seat, that heat there is far more than body temperature. If you travel from here to Pretoria with a heated car seat, which means you're actually frying your testicles from here to Pretoria. By the time you arrive in Pretoria, your testicles will be like boiled eggs. They won't be functioning very well. If you look at this person as he's seated like this, if the car seat is heated, which organ is heated mostly? Receive the heat. The scrotum. And some cars, they say, even my car, even the back seat can heat. That is not something to praise yourself of. There's an aircon in the car, you've got clothes, it's never as cold that you can even shiver. Don't go for the heated cars. I don't know who made heated car seats. They are very dangerous. Because they affect the sperm morphology. You find that a normal sperm is a sperm like in the blue here. But you find that the sperm that are produced in all those conditions that I mentioned, except together with the heated cars, they form sperms with big heads, small head, globular head, abnormal head. There are a lot of head defects. Some people with 2 heads, some sperm with middle piece effects. The sperm in the middle piece, they've got mitochondria. That's the energy of the sperm come from here. They've got defect yet, so they can't move. Some have got short tail, double tail effects. Some have got no acrosome. There's so many morphological abnormality of sperm such that if you look at a sperm under a microscope like this, An experienced andrologist will be able to spot this, but majority of them, for being more accurate, you must use special stains so that you can see the sperm very well stained, whether it's normal or abnormal, and you can be able to classify. Sometimes you use special stains that colors the sperms, and then you can be able to see the shape, whether the shape is a normal shape, or is a big head with a small tail, or is a small head, or is sharp head, or is double head, or is double tail. Many sperms has got many abnormalities. Any abnormal sperm, it doesn't have a fertilization potential. Like here, I see many. Look at this head is on the side. That one has got no tail. This one is curved. This one has got no acrosome. There are no so many morphological abnormal sperm. I like sperm morphology because, you know, I'd give you history. In 2001, 11 September, they call it 9/11. I was in the laboratory in Tigerberg Hospital doing sperm analysis. My duty for that week was sperm morphology, sperm analysis to analyze sperms and report. And I realized that there are no more girls in the laboratory. All the laboratory staff is gone. I said, when I finished, I found them in the tea room watching TV. They are watching the Twin Tower. When the Twin Tower was hit by 2 planes, they were watching it, and they left me in the laboratory alone doing sperm analysis, sperm count, look at the morphology and other things. You look after it in a microscope like this one, and you take your time, and you can be able to see whether they are normal. You can see the count, you can see the motility, you can see the shapes, all this. There are a lot of abnormal sperm parameters that you can report if you do sperm analysis under a microscope. You can be able to see whether there's oligozoospermia. When the report says that your husband has got oligozoospermia, or you are a man, you've got oligozoospermia, it means your sperm concentration, you've got less than 15 million per mil. It's not many sperms. You must have at least more than 20 million per mil to have a normal fertilizing potential. Or they can say you've got asthenozoospermia. Asthenozoospermia means the sperm, they've got no progressive movement. At least less than 32% of them have got no progressive movement. They just move on one side. They are not moving forward. The movement must be progressive so that if deposited in the posterior fornix of the vagina, they can enter the cervix and move forward. They can't just shake, sit in one place. If they say you've got teratozoospermia, terato means too many morphologically abnormal sperm. Either they've got a head abnormality, they've got tail abnormality, they've got a middle piece abnormality. At least more than 5% of the sperms must be normal for you to fertilize. There's a condition which is called OAT syndrome, which is oligoasthenoteratozoospermia, which means you've got oligozoospermia, you've got asthenozoospermia, you've got teratozoospermia in one person. That's why it's called oligoasthenoteratozoospermia, OAT syndrome. All the above 3 parameters are abnormal. And OAT syndrome is one of the irreversible sperm abnormality that causes total infertility. A man with OAT syndrome will not be able to fertilize anything, even through assisted reproductive technology. It's very difficult because either you'll find the sperm that doesn't move, the sperm that does they are few in number, and majority are abnormal. If they report that the report is azoospermia, the person is azoospermia, which means inside the semen that he ejaculated, there were no sperm detected. He doesn't have sperms, but he's got semen, because semen is produced by the prostate and the seminal vesicles. So you can produce the semen. This thing that you see you call sperm is not sperm, it's semen. The sperms are inside it. And for good fertility potential, the spermogram report must be normospermia, which means all parameters of the sperms must be normal. And normospermic man doesn't have infertility, male infertility. And how do you evaluate a person or a couple for investigation, more especially male infertility? You must take a good history. And the history, I believe, like that, people approaches are different. I believe you can take history with them together, couple together, then separate them. Call the wife to come one day, take a history. Call the husband to come one day, take a history. But there are things that one partner cannot say in front of another partner, just to maintain dignity. And even examination, you might have to do it separate. An investigation, you have to do it separate, which bring an ethical dilemma. We'll come to an ethical dilemma of separating investigations. And you find that investigations in a man are not favoring reproduction. How are you going to divulge it to the woman if you have separated it? It's a dilemma, but at the end of this, I'm going to present something which is not a solution, but you'll come with a solution. You must take history, good history of infertility, duration of marriage. You don't marry this week, next week you want a baby. There must be at least 12 months of unprotected, unrestricted sex for you to say you've got a problem with infertility. Some couples, they marry, after 3 months, they start consulting, looking for a baby. No, it's premature. You must ask about past conception with the present or previous partner. Even miscarriages, ask about them. This is the things that's why it's important to separate them, because a woman will not tell her miscarriages in the presence of the new partner that I have. When I was at college, I had a miscarriage. When I was at university, I had 3 miscarriages. No, no woman, no clever woman will tell such things. And ask about previous investigations that were done. Most people in a man, if a man has done investigation and the investigation they said she's got azoospermia, you ask in front of the wife, you're sure that you're not going to get the right answer. But if you're alone, you can tell the right answer. And take a sexual history. I said, ask about the frequency of intercourse. Whether are they likely not to miss the ovulation period, because there's that critical 4 to 5 days that is important, that around ovulation where pregnancy is likely to occur. Also, I've said that too frequent intercourse and masturbation, it causes a small volume of semen and small volume of sperm, so it's not good. And also, too infrequent one, it causes sperms that are dead. And then ask about erectile dysfunction. Ask even from the partner, because the man might say, oh, no, I'm fine. Ask about from the other partner when you, in treatment of infertility, that's why you separate. And male infertility is the only condition where a gynecologist ever examine a male. There are some people who have got dry sex. They've got this habit of using the lubricants to make it dry, and they buy it over the counter everywhere. They don't know the contents of that lubricant. Majority of these lubricants, they contain what they call non-oxynol 9. They've got chemicals that will kill the semen. So you don't just buy anything because it can lubricate and use it. Ask about his medical history. Diseases like diabetes, hypertension, respiratory disease, neurological disease, medication that are used to treat those diseases can cause male infertility and even impotence. Sexually transmitted disease, I've just alluded that they can cause infertility. I want to show you what diabetes does. Diabetes causes, it reduces the lumen of the vessel. This is a blood vessel. It causes a plaque here, which is called atheromatous plaque, which either blocks these vessels or reduces the lumen of these vessels, so that blood flow through the vessels pressure is not too high. That's why a person with diabetes have got erectile dysfunction, because for erection to occur, you need a blood flow in a high pressure into the corpus cavernosus and corpus spongiosum of the penis. But if there's atheromatous plaque of diabetes there, the blood flow is very weak, and it says that erection is flaccid. Now, of course, you ask about sexually transmitted disease. They hide it. Even to themselves, when they look at it, they must look at it separately. Even if the man and couple are sleeping together, if the man has got penile discharge, a woman will never know. He will never tell you. Surgical history, whether you have done vasectomy or not, any testicular operation for the varicose vein, for hydrocele, for inguinal repair, which you can see the scar, for prostate, transurethral resection of the prostate, for benign prostatic hypertrophy, whether you have previous strictures, which is from gonorrhea or other STI, whether you've got penile surgery for hypospadia or epispadia, which is condition that I said it happened during childhood, which I encourage you that you must do it during childhood. This is just another picture to show If you cut the communication between the vas deferens and the testis by vasectomy, you will have infertility because sperms won't pass there. Another condition which can occur in male is what you call hydrocele. If you look here on the left, the testis and the scrotal sac, there's no little space. But here there's a fluid which separates the testis from this one, and the testicular bag becomes huge, very huge testicular bag with fluid inside here, water inside here. It's called hydrocele. This hydrocele, the mechanism by which it affects fertility is by increasing the temperature of the around the testicles. As I've said, that you need a temperature about 4 to 5 degrees below body temperature for good spermatogenesis. Surgery for the benign prostatic hypertrophy, which is very common in men above 40, can sometimes injure the valve of the bladder. And when the semen comes here, you ejaculate inside the bladder, which is called retrograde ejaculation. Let's just see this one, which explained better than I explained. There are some things that are explained better than I do. It's varicocele repair. This is the, how do you want to know that there's a varicocele? If a man examines the testes and feel that, as you said, they're not painful, and feel it's like you've got spaghetti there, you've got a bag of worms in the testes, those will be varicocele. They will not cause enlargement of the scrotum like hydrosol. They will not cause pain, but they'll increase the body temperature there. They'll cause low sperm count. You just examining the scrotum as you wash in the morning or during the bath, and you feel that around the spermatocord, it seems like you've got a bag of worms there. Then you know that you've got varicocele. Of course, on history, I've said that you should look at the following, like MAMS, scrotal injury, testicular torsion. We'll talk about testicular torsion because it is very important, and multicentered testes. And the parents know developmental milestones of the children, whether they were delayed or not. Delayed developmental milestone usually herald the problem that this male might have male infertility factor as time goes by. And the type of job that is doing can cause that. If you look at these testes, these are the Pambiniform plexus of Bates. If the testes twist around the spermatocord, the twist around this vas deferens, it's what is called torsion. And if you twist around here, like coiled around here, it obstructs blood flow from the drainage from the testes and flow into the testes, such that this testis is deprived of blood, deprived of oxygen. That's a condition called torsion, and it is painful. If torsion can occur in a testis and 24 hours elapse after torsion, 24 years, the testis not supplied with blood, it dies. If you look at the two testes here, this other on the right is dead. The best thing is just to remove it because it will never recover. But if it happens acutely, and you suddenly go to the nearby center where you can be helped, they detort it and fix it, which is they called, they pax it and fix it there so that it mustn't coil around itself again. The fertility might be spared, but majority of them, because we stay far from health facilities, by the time she arrived for surgery, to do a procedure called orthopexy, where they fix it so that it mustn't turn around itself, is too late. Majority of them get removed. Fortunately, the good Lord made two testes, not only one testis. Occupational problems. People who have got occupation that moves them away from their partners. That's a male infertility factor problem. More especially, distant truck drivers. They've got several problems that cause them infertility. One, they're absent. Chances are that by the time they come home, it might be you can spend 3 to 4 years, a husband coming home at a time when it's not conducive, at a time remote from ovulation. So he'll not be able to impregnate the woman 4 or 5 years elapsed because the husband, when she's home, his time at home is so short that it doesn't even coincide with ovulation. Secondly, is that they drive a long distance sitting on the seat here, sitting on the scrotums, increasing the scrotal temperature. Some drive trucks from here to Cape Town with scrotal temperature here. With that temperature inside the truck, the engine of the truck is just below here. It's hot here. It's like that heated car seat. The sperm count is low, sperm motility becomes slow. Thirdly, they are prone to sexually transmitted infection. This is a normal observation. If you go to anywhere, any town where trucks are overnighting, you must see women there. They didn't come with those trucks. Everywhere they overnight, there are women of that area. It's like flies when they see milk. If you can just put milk there, you'll see flies coming in. You don't know where the flies come from. If trucks can just be near your town or near your village, there's a place where trucks overnight. The first thing that you're going to see there is this type of semi-naked women going to the trucks. And these are sexually transmitted disease carriers. That's what I call them. But in South Africa, because we like sugar-coating things, we don't call them sexually transmitted disease carriers. They call them sex workers. They say their job is sex workers, and they've got the right to go to the right to go to the truck driver and give the truck driver a sexually transmitted infection, and the truck driver becomes infertile or infect his wife, and so on. This is common. Truck drivers are very much exposed to become infertility because of their absence, the heat that they go there. And this, that when I've said that whenever a truck stops, it's like when you've got milk on the table. Once you get spill milk on the table, 30 minutes, there'll be flies there. Once a truck parks, these semi-naked women come there and they bring sexually transmitted there to that man. So truck drivers are very prone to have infertility. But as I said in my beginning, women are clever species. They've got a way to circumvent and go beyond male infertility. If a man is a truck driver, it doesn't mean children will not be there. There'll be children in the family, and those children will belong to that man, because according to our culture and religion and belief in African religion, any child who's being, any pregnancy which is in your wife belongs to you. There's no proof. There's no genetic test. A wife cannot be pregnant by another man. If he's pregnant, you are pregnant. So when you do examination, which you can do both on what, you must examine the scrotum and feel the vast difference, whether we don't have those varicocele or not. And look at the size of the testis. Usually in the rooms, you have got these measurements of the testis to measure the testis. You say, does it look at, a normal testis should be size 12 to size 20. If you've got testis of size 3 or 5, you must know this person might have mumps while young, now she's got testicular atrophy. Smaller testis usually is due to a disease. A normal person testis can either be size 10, 12, 15, or even 20. So the smaller the testis, look for the cause if you can find it. Majority of them, unfortunately, are not treatable. When you look at the abdomen, whether she has had inguinal hernia repair or she has got to repair for undescended testis. Inguinal hernia is that condition where you've got a bulge coming here in the inguinal region. It also occurs with undescended testis. You've got that the testis is seated here. So that is the type of examination that we must do, genital examination. The only time I ever examine a man is when I examine for infertility. I don't like examining men. I'm not good at examining men. I examine women mostly. Dr. Monari and Dr. Mushuka examine men daily basis. They'll tell more about how they examine. How to analyze the semen. When they analyze your semen, they say go for sperm count. They want the volume of the sperm. It's a certain volume that a person who abstained for 2-3 days must produce, which is about 1.5 to 2 centimeters. The duration of absenteeism, motility, morphology, the color of the sperm, the viscosity of the sperm, many things, and the morphology. And the World Health Organization in 2010, they revised their criteria. I said the volume should be more than 2. They revised it to more than 1.5. And it used to be 20 million, the sperm concentration. They revised it to 15 million per male. They reduced the criterion because there are certain type of men who will have fertility at lower parameters than before. Even the morphology, which is like this, they're a bit not strict like before. This is a normal sperm. You can see it differs from this one, which is tapered. It differs from this one with big heads, the one with 2 heads, the one with 3 tails. Morphology of the sperm, as I told you, that you look at the head defect, middle piece defect, you look at the tail defect, or the head without acrosome, which is called globosome. And they do hormonal investigation, including the follicle stimulating, testosterone, which is an androgen level, prolactin, I've told you that it produces milk, and the thyroid stimulation and the karyotype also do. The chromosomes test can be done on a woman to see whether, if a man, if she's a woman, she will have an XX on the sex chromosome, which is a man should have an XY. Some people have got Y deletion syndrome. They've got an X but no Y, which is called a male Turner, which is called Noonan syndrome. And when you look at that man like this, you won't realize that this person has got genetic disorder. That's why you must take blood. And in the semen analysis, I've said that you must, it is 2 to 3 days, not more than 7 days. It's too much. Short interval of abstinence decreases sperm density. And long interval of abstinence increase the number of dead sperm and immortal sperms. So if a person is more than 10 days not having sex, it doesn't mean he's got good. The majority of sperm there are old, they're dead. Some of them are not even normal. We have described this, what this means. The oligospermia, asthenospermia, teratospermia. We've described it in old syndrome. We want to go to globospermia. Globospermia is one of the commonest causes of sperm abnormality that we can see. And necrospermia, which is caused mutual necrospermia, means all sperms are dead. Globospermia means they don't have acrosomal cap. Aspermia means no semen in the ejaculate. And you find that when you look into the microscope, you find that the normal sperm count should be concentrated. And if the sperms are scattered under the microscope, that is a low count, low sperm count, they won't be able to fertilize a woman. So it's called oligospermia. While abnormal forms, too many abnormal forms is called teratospermia. If they are not dead, they are not mobile, it's called azoospermia. And if they are few, but they're there, it's called oligozoospermia. Majority of men with the ejaculatory disorder will have aspermia, no semen in the ejaculate. That's what it is. And usually it's caused, those are caused by hormonal imbalance. It can be caused by spinal cord injury, can be caused also by uncontrolled diabetes, medication, alcohol consumption, and many genetic conditions can cause that. The investigation, as I said, is multidisciplinary. I still want to show you a normal sperm, how it counts. It's got a tail, the middle piece, and the head. So they must sit in your head. This is abnormal form of sperm. If you look at this sperm, it's like a tennis ball. It's round. It's a globospermia. And I want to explain you more what globospermia does. You see, it doesn't have these sperms, they don't have the acrosome. The acrosome is moved away. If you move the acrosome from the sperm head, you've got a sperm which is round like this. And because this acrosome contains enzyme that is responsible for fertilization, you miss those enzymes, you won't be able to fertilize because those enzymes are found in the acrosomal reaction, which the process that takes place and enable the sperm to fertilize an egg. So this is globospermia. When you look at the sperm under a microscope, it needs concentration. Counting sperm is like counting chickens. If you try to count chickens, if you count this one, the other one moves the other side. Count this one, the other one move this side. It needs a lot of concentration. And you find that the sperm chamber there is divided. You count only one chamber and count another chamber, and you say the average is so much, and you give it's never an accurate number. So you look at the sperm when you count them, they are moving like this. This one is normal sperm count. This one you can see they're not moving, it's asthenospermia. They're just shaking in one side on the right. And this is a normal sperm count. And you've got to count them under the microscope while they are moving like that. To count in one section here, how many do you find? In another section, how many do you find? This one is just moved from one chamber to another one. So it's like counting chickens. So if you count one by one like that, that's why you've got to count 3 to 4 times for you to say this person has got a low sperm count or has got a high sperm count. Don't just count once. And it's very tiring. I've got to sometimes sit. I sit and relax sometimes with my neck tired and continue counting again. These erection and ejaculatory disorders are very common, and the partners and the couple who complain about it. Erection, I mean the state of arousal which allows the male to have intercourse. Should a male be unable to get or maintain erection, it's referred to as erectile dysfunction, which is treated mostly by people who deal with the men's clinic. And ejaculation refers to the act of ejecting semen from the sperm. Don't be afraid to ask whether erection is there or not. This is one of the questions that you must ask while the other partner is not there, or you ask it, you hear it from the female partner, whether the male partner can have a stiff erection. Female can tell you whether erection is a good one or what, because majority of female had experience from getting erection from one man to another man. You can compare and contrast it. This erection is not like that other previous girlfriend. And then you can tell whether my present partner is not as hard as the previous partner. And then you can know that this man probably has got some ED, erectile dysfunction, and treated like a men's clinic. And she has got a ejaculatory disorder where she cannot ejaculate semen through the urethra with enough force to force the semen to go into the posterior fornix and move up the cervix and move up the uterus to go and fertilize an egg. If a man has got ejaculatory volume, you ask about it. People with congenital bilateral absence of the vas deferens, or people with obstruction of ejaculatory ducts, or people with hypogonadism, retrograde ejaculation, if ejaculation is into the bladder, you'll have absent or low ejaculation, low volume. If you've got high volume, it's not always a good thing because it might be inflammation of the accessory glands, either the prostate or seminal vesicles, the gland that produce the semen, which is seminal vesicles. So high volume doesn't mean good. It might mean a good, poor prognosis. For those medical doctors who are here, if you do blood test, you find that FSH is high, LH is normal, and testosterone is normal. One of the problem is in the testes. There's a failure of spermatogenesis. But if gonadotropins are low and testosterone is low, the problem is high in the hypothalamus, in the gonadotropin releasing hormone, is what you call hypogonadotropic hypogonadism. So this test can tell you where the problem is, whether it's treatable or not. And you can do testicular ultrasound, but testicular volume also can be able to see. In the meantime, you can also assess the prostate, whether there's obstruction, or you can even take a biopsy of the prostate. You take a biopsy of the prostate only if you've got facilities for sperm cryopreservation, because usually when you take biopsy of the testes, you take it together with the sperm from the seminiferous tubules in order to cryopreserve them in preparation for assisted reproductive technology called ICSI, intracyclospasmic sperm injection. You inject the sperm inside the cytoplasm of the cell. What do I talk about cryopreservation, which is a process which by people call it sperm banking. They are going to the sperm bank. They preserve those sperm there. This process of collecting and freezing and storing sperm so that they can be used later is called sperm freezing or sperm cryopreservation. It's not a bank. A bank has got interest. This one has got no interest. The sperm can be thawed and used in future for the procedures such as intrauterine insemination, in vitro fertilization, intracytoplasmic sperm injection, and IVF. The sperms are cryopreserved inside the carbon dioxide chamber, which is high chamber with liquid nitrogen. After being treated, the cryopreservation in place in a vials and can stay for years there. Especially if a man is going to go for treatment of cancer or something, you can take sperms and cryopreserve them. But if you've got testicular function, you can cryopreserve them, go and examine, and take sperms that you think are better and fertilize with them. The cryopreservation bank galore in most centers, they've got these tanks which has got liquid nitrogen inside, and they preserve the sperms inside it. The management of male infertility can be medical, surgical, or assisted reproductive technologies like IVF. These are the steps that you take to the IVF. You stimulate the ovary of a woman, you harvest the egg, you take the semen, you analyze it, you take only semen that are better, you fertilize the egg, you transfer the embryo inside, because fertilization takes place outside the body. You put it inside the uterus, and you do a pregnancy test. If you are lucky, pregnancy is there. And you take this egg through a needle under ultrasound guidance. Through a needle, you can take an egg from the ovary to be fertilized outside. And when the fertilization took place, you can put it inside the ovary through a needle also. While fertilization took place in the petri dish, in the laboratory, that's why they call it in vitro, not in vivo fertilization. Sometimes under ultrasound, you can put a needle through the vaginal ultrasound and prick the ovary there to harvest an egg in a woman so that you can use a sperm in the process called intracytoplasmic sperm injection. They take, while you look at the sperms, and you take the sperms that you think is most normal, you suction it inside the syringe, and you fix this cell which you have taken from the woman, which is an egg, and inject the sperm directly inside this cytoplasm of the cell. That's why it's called intracytoplasmic sperm injection. You inject it here. You see the sperm is inside the cell, is injected, this ICSI. You actually fix this egg with a pressure suction here so that it must move around and inject it. This is done under a microscope, very steady. You must do it very steadily, otherwise you can spoil the egg or you can inject it outside. You must go smooth. The injection that you use there is a micropipelle, which is made of glass, very tiny thing. That's why you need microscope to inject it. And if it becomes, there's a fertilization after that, you really feel the joy. Towards the end, I want to say, people, approach to a male infertility, you must use diplomacy. It's a very sensitive issue. It needs a person who has got compassion and diplomacy. Diplomacy, I mean the art of dealing with people in sensitive situations. You must be tactful and have compassion. And again, there's a lot of controversy in the midst of cultural belief. The fact that also, as I've said, that male infertility, mostly in Africa, doesn't exist. And the reason why it doesn't exist is believable, because even if there's male infertility, there are always children. Women has got the way to override the male infertility. So if you've got male infertility, how do you divulge it? I want the urologists to tell us that if you find a man has got old syndrome, do you tell this couple that this man will never fertilize you? Because if you tell that man that, you tell the couple together, tell the wife and the man together, which means you have said that woman was never fall pregnant. Because if she falls pregnant, the man is going to suspect. Or you keep quiet and let the family go. Because the main reason why they came to you, they want a baby. But you want to, at the end, for them to have a baby. It's an ethical dilemma that you cannot solve. But I think during discussion, you'll tell us what you do. Whether you tell them both, you tell them separate, or hide result from one from the other. On the other hand, if you tell the wife of the man's problem, I will not break in doctor-patient confidentiality. But if you tell them doctor-patient confidentiality, you don't break it if you tell them together like this, because he's just close by. He's here telling the husband what the sperm count is, and she's just here by proximity. That's not breaking doctor-patient confidentiality. Breaking the confidentiality is when the wife comes to consult you alone and you tell her about the husband's poor sperm parameters, because that way you might cause problem. Because in one of the 4 pillars of ethics of medicine is that do not harm, primum non nocere, do not harm. Harm in this way, I mean, do not destroy the family. They came here as a family. Don't at the end when I be the one who destroys the family. Build the family. Actually, they come here with one goal. You must help them to achieve a desired goal. What is a desired goal? A baby in the family. Make sure that there's a baby in the family. I'm sorry. You know, Africans, we don't. I've mentioned name Klinefelter syndrome, Noonan syndrome here. People name their heroes on issues that the heroes did. Africans, we don't do that. Who is the first first African? I don't say black because according to this government, even Chinese are black. Let's say African, so that because according to me, only Africans are black. The first African gynecologist in South Africa is Dr. Machupi Mphahle. People confuse it with the Prof. Ephraim Mogokong. Prof. Ephraim Mogokong is the first African gynecologist to qualify in South Africa. Machupi Mphahle qualified in England, but he qualified before Prof. Mogokong, so he remains the first African gynecologist in South Africa. Now, he has got a certain approach, which I want us to name him, to honor that man. It's my hero. It's a Machupi infertility approach, where he used, there's a cultural integration in the male infertility management. He integrated culturally and everything. So we'll come to it. Machupi's male infertility approach. If you ask me thereafter, I'll tell you what he was used to do, but it's a cultural integration in the treatment of male infertility. Because male infertility, as I say, you must have compassion. It's a social stigma. You can break somebody's heart if you really not sensitive with your words and say things as they are. Sometimes you got to tell a bit of a lie in order for a man to remain a man. You can blame a couple that was loving, jolly couple, bubbly, if those results, you don't convey them nicely. So sometimes in medicine, it's good not to say some things, even if they have to be said. But most people with male infertility, if you don't say there is azoospermia, chances are that there may be a baby in that family, and then the man will be happy. But if you break the man, you break everything. And a few doctors who are here, I want them to tell me, and Dr. Munari is here, I hope Dr. Mushoka is here, to tell me what's the best approach for this. But I'm very ethical. I don't just open my mouth and say things, because I respect people. They come to me here, they love each other. It's a nice couple. I don't want to destroy a family. Premium non care. There's this thing, there's mental colonization in Africa that everything European or American is civilization to an African. And everything African is barbarism to both Africans and their colonizers, the West. Anything which is African is said to be barbarism or is a superstition or what, but any African American barbarism is civilization to Africans. I think that Africans don't like themselves. That's why Malema said, you've got self-hate. Like this issue of sperm donor, it's an American thing. How do you donate sperm of a person that you don't even know, you don't know what disease which he has, but it's saying that you go for. But you can't go for Tlatswadirupe. You see, but with Tlatswadirupe and others, the person you know, it might even be a relative. But should African scientific method of treating male infertility be abandoned or utilized? I think they must be utilized, because in Africans, we utilize the semen from the family. You know, even when this child has got problems in future, passage and we know where to go because he belongs to the family. Unlike sperm donor, you don't know where this person comes from. Maybe they come with diseases like schizophrenia and other diseases that you don't have in the family. So I want you to approach it from African perspective. And I think African treatment has got a place in male infertility. And I like it. I've used it several times with success. When I go to Africa, we deal with women. Women are very good in keeping secret. That's why I want you to, after listening to this one clip, thereafter we close, we're doing discussion to address whether there's sense in this clip or there's nonsense in this clip. Ladies and gentlemen, this is all I had to share. This is a very huge topic, a very huge topic. I just decided to share this, what I share. You can talk the whole day about male infertility. I hope our panelists, all of them are here, but I haven't talked to Dr. Mushuka. If he's here, once I unmute you, she can tell me whether she's around. If she's not around, Dr. Munare is around to answer your questions. Dr. Mushuka, if she's around, she will answer the questions also. So this is Dr. Munare. He's a urologist here in Petersburg. This is his number, because from here, many are going to come to me. There are a lot of things. Dr. Munare will treat more things than I have to treat. Even Dr. Mushuka will have to treat more things than I have to treat. That's why I put their numbers here so that you can see them. If you want their numbers, you can even phone me later. I'll give you their numbers. And then from there, we'll have questions and discussions. But I think I must tell you that I receive a lot of questions on how to get the invite for these webinars. Some get it from my Facebook, which is Dr D T Mahapa. And if you want to be on our database for invite, the office will invite you directly. You can email or WhatsApp or SMS your email address to 079 620 5858. This is the number in the office. The lady will give you will keep you in their database and inform you of these coming webinars directly. But majority get it from my Facebook. Thank you very much. Let's start with questions and answers. Let me unmute you. Okay, I think I've allowed you to unmute yourself. Are you audible? Dikezo, I see your hand is up. Dikezo? What's going on? Dikezo? I see, are you not able to talk? Unmute yourself.
Yes. No, I raised my hand while that clip was playing. I just wanted to inform you that there's no audio there on that clip.
Which audio?
That clip that you shared there at the end.
It did no audio.
Yes, there was no sound. We didn't hear nothing.
Let me see, my friend. It's good to inform you of that. Let me do like this. I'll go to I'm going to go to, I think you should hear that audio. It's very important. If there's no audio, you must tell me. I've unmuted you. I'll play it again. Is there audio? Is there audio, Peter? Is there audio, Peddler? Are you there? Is there?
Still no audio.
No audio?
Yes.
Let me see. Just hold on.
Mosadi wa go palela ke go godiša kgoro go ba go oketša thari a sene thari re mmetša moopa
Yeah, it's playing now.
moopa ke monna moopa ke mosadi gomme ge monna a hlwa ke go oketša kgoro goba gona a negile diphehlo puleng go dira le go tshetsheta ba re kukang dikgetlo gobane mmile go sanka wa butse ka go bona tšhweni go dira ke ra gore magagešong madumešie bonna ke ra moši kgomo ya mošate ba re wa gapa molato wa lesa molato ke lesika le lepale tše bana ba re ke nama gore metšela kgone ka banna ba bošo ke iteremeita le kgonne ke tlo araba potšišo e botšišego ke bo morwarre le bo dikgaetše di fa bana ka go tseba gore na ge monna a palela ke go swariša kgole goba a palelwa ke go netefatša gore o oketša kgoro a enegile diphehlo puleng go dirwang ka sepedi a ke thomeng ka go letša fa gore monna wa go palela ke go swariša kgolo goba a enegile diphehlo puleng goba wa go palela ke go oketša kgoro re mmitša nyopa mosadi wa go palela ke go godiša kgoro goba go oketša thari a sene thari re mmitša moopa go na le nyopa le moopa nyopa ke monna moopa ke mosadi gomme ge monna a hlwa ke go oketša kgoro goba gona a negile diphehlo puleng goba a šitwa ke go swariša kgole mo kgorong go be go napa go eba le tshepedišo e be e lataelwa monna o ba nyakišwa goba ke re ba nyakela ra ngwane ya tšona go ya ka kgati goba ke re go ya ka kgoro ka mokgwa ba tsibanang ka gona gomme e be yena mo tsenelago tšhemong ya gagwe go mo thuša go atiša kgoro ye rangwane o belega goba ke re o belegela morwarragwe bana ge fela morwarragwe a šitwa ke go oketša kgoro ba a negile diphehlo puleng re ya kwana kere taba ye be e sepetšwa ka sebopego se monna yo re mmitšang rangwane ke wa kgoro o ba tsena tšhemong maraga gore monga tšhemo a tsene monga tšhemo e le go yena o a negile diphehlo puleng o ba tsena pele gomme rangwane a tla tsene ka morago mohlho mongwe a kere o le matšhemo bošego a lalala madipanga tše a di lemago ge go esa monga tšhemo ba moroma kgolokgotswaneng ke gore ba moromela kgole gore a fera ngwane sebaka sa gore a tla tsene gomme go dira bjale ke gore ge a ye go bala matšatši le dikgwedi tša ge nnete gona a fetša go lema gomme go laetša gore mabjala a mela mo tšhemong ya gago a hwetše nako e lekana go ya ka dikgwedi le matšatši go ya ka mokgwa a tseneng ka gona gomme tabe be ba sephiri ba sepipimpi thopa kgororo khupa maramarekgwana e re yana e badimong rangwane ba sa tsamaya le tša phala pepenketše ditaba a re yena ke ena mogodiša kgoro ya morwarragwe e ba no di gata e ba tša gagwe gomme go fihlela a fetša go belega thari eo monna a kgotsofala gore yena a se nyaka thari o tloga ka ngwana mathomo go fihla kwa mafelelo e le
That's what you have heard about that. Thank you. I will ask any of the Dr. Munari, if you are here, would you like to comment, just to greet them and give them a little comment? And then thereafter they can ask questions, me and you can see how to tackle. And Dr. Mushoka, if you are here, I haven't seen Dr. Mushoka. Dr. Munari, are you here? Good evening. Dr. Munari? I think our participants, they didn't come in, our urologists. But I asked them, they agreed. Okay, fine. Let's go, without them, let's go directly to the question, answer the questions. Do you have any questions and any answers or any contribution? I saw people like Oti, I saw people like Dr. Mutlanti, I saw more than 5 doctors here. I think I've unmuted any. Mania, do you have to say something? Let me do like this. I've allowed you to unmute yourself.
Oh, Doc, I think there was one who I don't know which doctor is it. They just said they were unmuted. They were muted.
Okay, now
So,
I've unmuted them now. I see Solimutlanti's hand is up. Sola, how are you?
Good evening, colleagues and Dr. Mahapa. Thanks
Good
for
evening.
this very huge topic. Unfortunately, I joined a bit late. I was still busy. I might have missed some of the discussions, but as a contribution or comment, with especially environmental factors and medications that can affect infertility, one must be aware of cimetidine, the one it treats for reflux and peptic ulcer. It's normally prescribed for months and so on. So people must ask about that because it can cause male infertility. The other thing is ketoconazole, the antifungal drug. That can also do that. So history is very important, as you said, Dr. Mahapa. And also, people who are living in the farms, for example, pesticides, fungicides, environmental toxins are actually very important in the history. And the other thing which one must not forget is exogenous testosterone and androgenic steroid supplements. Today, you see men with big chest and big shoulders like pit bulls. So those people also, and there are many. That's why you said, for example, in 1940, the sperm count per male was 113 million. In 1990, it was 66 million. Now, in 2000, it's 36 million. So we're going down and down and down. Alcohol, drugs, steroidal use, and all those things. The other thing is COVID. COVID also had some hand in causing infertility in those who had a very severe infection. I'm not sure if Doc, did you speak of any specific treatment
Only after 30 minutes.
or we are leaving that to the urologist, especially medical treatment in certain cases? You talked about, I think, surgical issue, IVF, intracytoplasmic injections, and so on. I'm sure the urologist might add some of the drugs, especially in what they call idiopathic infertility, where you can get drugs like carnitine, tamoxifen, and they talk about antioxidants and so on. Yeah, so maybe the urologist will talk about that. But those are just what you call my comments. And when you spoke about the tight underwears, especially for young people, which is good, if they are still, want to make children, they should avoid that. Only old men should wear those because they don't want children. The young people must wear boxers. Thank you.
Okay, thank you. Nice contribution. You've augmented that. Unfortunately, it seems like the urologist that I agreed with.
No, I am here. I think you've managed to unmute me, Dr. Mahapa.
Oh, where are you, Dr. Munaris? Dr. Munari, how are you, my friend?
All right, how are you? I've been listening through, and thank you so much for a very extensive discussion around male infertility. I've certainly enjoyed it, and I hope the rest of the audience have enjoyed that. And I think you've covered almost everything. I would not even myself have phantom that I could go that much. I'm really satisfied with that. It is indeed quite a common problem that we get, and the dilemma that you had actually alluded to, especially with regards to the very last presentation, the last slide that you played. There's always been a huge personal, ethical, and difficulty in having to manage or deal with those patients that, say, for instance, a person that has got complete azoospermia, and as to just how far one can go with regards, I heard you talking about not wanting to destroy families, which is obviously, and not wanting to harm families, but at the same time, one is then faced with not knowing as to whether one can then be dishonest to the to your patients, which would be male and female, when they would have presented to you. And I suspect with development and technology in the years to come, where we would then be able to can achieve, say, childbirth or childbearing without having to actually use gonads. When that time comes, when we can get to levels of cloning, and I'm not sure how far away we are from that. Are we 10 years away from that, or are we 20 years away from that, or 30 years away from that? Then the ethics would change. And the question that you have asked as to whether we should disclose completely and say, listen, gentlemen, you've got azoospermia, you've got no testes at all, so there is no chance that you could ever have children and crush that family, or whether there is still hope, you know, for those patients. I think it is always a very difficult thing for the doctors that are attending to such a couple when it comes to such matters. But truth be told, in my practice, I always give hope. I always give hope. I would always go to an extent of saying, this is a difficult situation. Maybe something will turn up. And if I really find myself in a tight corner, I say, hopefully in the next few years, there might be a technology that comes in. In the meantime, would you not perhaps consider adoption or something like that? I think I'll take my cue from the rest of the audience as to, you know, how far one would go with such a moral and ethical problem.
Thank you very much, Dr. Munare. And I want to share, which I call it, you know, perhaps somebody must call it. I want to honor the first Black gynecologist in here, Machupe's method. Machupe, when he faced with such situation, and he has to explain to the wife alone and say, what's your duty in this family? You are married to this family, is to make children. And if you fail to make children, you'll be failing in your duty as wage in this family. And in the wife, in the husband, he will give a false hope, like you say. Maybe sometimes the chances are small, and then he tells the woman that you have to make sure that you make children. If you don't make children, this husband is going to is going to have a one-night thing with somebody outside. And somebody will claim that he's pregnant from your husband, and your husband will dump you for that woman. Make sure. And in that way, the woman knows how to read between the lines. You know, there will be a child in that family. It's true that you don't have to crush them all together. Give a room for a child to be in the family. But nowadays, you can't use that method of that clip where the Ramani are saying, because they might go in and not come out. And they don't keep secrets. They usually, when the cousin went into the family, they start making enemies in the families. You can't use the old method. But give a hope that let there be a family. The family must be there to counterbalance the effect of male infertility. Because if a man doesn't know that he's infertile, he remains proud. He remains the proud man in the family. And if a woman knows that one of these children doesn't belong to this man, he doesn't just go about undermining the husband. I want to hear from, not from doctors, from men that are here. We are Africans. Bo we limweng shiba. Mwengo. Why no lidia yung komlechi? Why no lidia yung wife? Nagarabotata. Wabakambega, how do you deal with this situation? You're the only doctor in that area. Happy? Dr. Munar, they are mute. They don't know how to deal with it. And I thought we wanted to...
yeah, let me just make a comment on that. Actually, you're right. When we grew up, we heard about these things, but as young people, we're not sure how they were done. And if you remember, during the olden days, men used to come home in December. Sometimes those who were traveling far, working far, they'll come after even more than a year. And then you'll find that there will be children, and some of the children might not belong to the father. But as Dr. Mahapa said, home. And this thing were kept very, very secret. But now, with these days of TikTok, WhatsApp, and people getting angry, they might expose the men on the, TikTok, you don't know. And the second worrying thing is that people who need, for example, IVI or intracytoplasmic, those are expensive. I mean, in Gauteng, the only center public that can help people is Steve Biko. And they are not coping. That's the only public center. Bara, Ellen Joseph, Calafon, whatever. Then if you go there, said infertility, they just charge you away. And hello? Sorry. So these are things that will tempt us to take the Machupe road, especially with hopeless, couples. Thank you.
Okay.
Okay, let me come in. Let me come in when speaking. Yeah. Okay. The people of our age, okay, we know those stories.
Come on,
I mean,
how are you, Willie Mwing? How are you?
Yes, no, fine. Yeah, we're talking about a very, very emotional matter. Right? Talking about a very emotional matter that, our ancestors managed to deal with it. It's just that we lost the plot somewhere on the way. I mean, if you have read almost all the books of OK Matsipe, they deal about this issue successfully and negative. For example, where I think it was in Lechufalela, where the traditional doctor, helped the woman. I mean, the couple came, it was even the king, and then the traditional authority or the traditional healer assisted, obviously unlawfully. And then we've seen also recently, I don't know, some few years back, the Swaziland issue, where some man from South Africa was being threatened to be killed because he disclosed that he slept with the king's wife, right? So we are no longer keeping the same things that were, the same way that it was done. But I think that was a better way of dealing with the matter. This now is very much complicated, and people no longer keep their secrets and so on and so on. We know of many families that have, they managed to deal with this matter, right? Even if you manage to hear those matters as a small boy or child, you dare not even talk. Even now, you can't even talk about those issues right now, so and so, what. But the other thing that I did not hear, I remember there was a story that was told that there was a couple, did not have children. I don't know what is this called, where, and then they all suspected each other, and then they all went out, and then they all came with their babies, and then thereafter they started to have, babies, together. So I don't know whether it's just a fantasy or it's a real issue, or whether when they say people of certain chromosomes and what have you, they may not necessarily have children. If you are related, that is something that I have not heard.
Just to come here.
But with these other issues of the old ones, I believe we could go back, adopt those African methods. I think we could somehow. And then also remember the issues like marijuana. No young person was allowed to smoke that thing when we're still, the Africans were still in control. That thing was for old people, even liquor and all those other things. So that is the plot that we have lost.
The age where you are allowed to be important.
Yes, yes. So, I mean, as a young person, the sport, there's other things. There were wars. There were, skills that you have to gather for lifelong, life. But now people as young as 7 years, 10 years, whatever, people no longer want to acquire life skills. They want the soft life. So that is our undoing.
Importance.
Yes.
I want to come in.
Okay, this one to come in is Dr. Makoti. He calls me Menier because I was a teacher.
Yeah. Yes.
Okay,
Yes,
thanks,
thanks.
William. Let me describe. I know him from young. When he qualified matric, he became a private teacher somewhere in Brussels. Then he later went to Thie to do his degree in agriculture and his senior degree. He's around here in Polokwane. Know him. Thanks, William. Menir Makoti.
Mayor, thanks. This was a very, very good topic and well prepared topic. You know, but Mena, just what I want to say is that we say prevention is better than cure. Rather than this presentation, even only to us, a few of us who are here. But I think the health educators in the clinic must go out and teach about this so that the young people do the right thing. Like you have just said, the way they dress and whatever thing they do, that they must avoid infertility just from the beginning, not at a later age. But thank you very much for this discussion.
Thank you, Dr.
Thanks,
Makoti. That's the main aim of this webinar, is public awareness. I'm trying to preach as much gospel as I can. You know, when you preach the gospel, in the Bible they say, a man was planting, some fell on the sand, some fell there, some fell there. So I think now I want questions now. Dr. Monari is here. Questions. Those that I cannot answer.
Yeah, sorry, let me just come back there. The other issue is because early identification of the problem is very key, right? Now, the problem is that how do we go about it? We know that in other fields, like in the military, and then some religious bodies, whatever, I think they do a thorough testing of the candidates, including, as they say that in the past there was a certain chair, you have to sit there, and then they must put a hand inside, and if the testicles are down and so on and so on. But we know that those things happen, but in other fields, in general, I mean, how do we deal with these matters too, so that we can, discover this matter at an early age?
Do you understand the question?
Well, yes, I do understand that, but I do understand the question. The thing is, invariably, infertility would present, say, later on in life when a couple plans to have children. Once in a while, you'll get an odd young fellow that doubts himself, that has been comparing sizes at high school or in a shower. A 16-year-old or a 17-year-old has been comparing sizes in a shower or after a soccer match. And then he starts thinking, maybe when I grow old, I won't get children. And now and again, they come in and ask to find out whether they can have children in the future. But generally, it will be recently married, or sometimes not recently married, maybe a young fellow whose friends already have children. 28-year-old or 27-year-old would come in and complaining and say, listen, I'm single. I'm not married, but most of my friends already have children. And it looks like I'm the only one that don't have children. And obviously, one would have to ask about, you are planning to have a child, but whoever you've been sleeping with, are they or were they planning to have children, But I think in this case, we're really looking at the couple that comes and approaches us with difficulty of having a child after having had regular sex over a period that you had already said, Dr. Mahapa, of around a year of frequent sex, uninterrupted over that long period, and there's no child. Then you can then say, we are probably dealing with infertility here. And invariably, then the two people get investigated. Most of the time, when they do present, in almost 90% of the cases, they would present to a gynecologist. And I think that stems from, maybe the way we were raised, that if a couple doesn't have children, chances are it is the lady that has got a problem. So majority of the cases, I'm saying 90%, probably even more than that, they end up presenting to gynecologists who will then investigate the male partner as well, and that's where we pick up these problems. Very few, very few would present, men would present directly to urologists to try and get themselves investigated for infertility. And those that do so, they most of the time don't even go there with their partners. They don't come to present us with their partners. They come secretly, wanting to make sure that if they do get married, they will have no problems and they won't be the partner, the one that is at fault. So they want, but they will actually say, no, into a relationship. But like I said, majority that do present would present to gynecologists, and that will be more than 90%.
Thank you very much.
So there would be no way we would then preempt it and say, let's investigate you for infertility if you've come for some other problems that have nothing, that are not related to childbearing or a wish to have a child.
Okay, thank you. Let's listen to, before David Mushuri, do you have your hand on? Thank you, Dr. Munari. Dr. Munari is our resident urologist. I've got his picture here. Mushuri, do you hear me? I see your hands is up.
Yeah, no, it's up, definitely.
Yes, what do you want to say, Dr. Mushuri?
Yeah,
Dr.
no,
Mushuri
thanks
is
for
a general practitioner in Kagiso. In Kagiso, is somewhere in Krugersdorp.
Yes. Thanks for the significant contribution regarding this topic. Yeah, I do understand that as Africans who are practicing Western medicine, we need to consider our cultural practices and try and strike a balance or a mix between Western medicine and cultural practices. But with the legislation that we have, I don't think we've got a very good opportunity of mixing the two, especially when it comes to mosadi wa monna wa butago. While it has been a very good concept, but I don't think as practitioners we can stand up and promote that kind of practice. Regarding full disclosure pertaining to infertility and who the main where the main problem lies, I think it is quite important to have full disclosure. Patients do move around, and whatever information that you don't disclose to them, they will get it from Dr. A or from Dr. B. And the patient will then come back to you and say, Doctor, may I please view the results of the test? And it will be quite heartening or disheartening and quite uncomfortable to finally disclose to the patient what the truth was initially. So as doctors, we need to accept that we are bearers of bad news most of the time. We tell patients about cancers, chronic illnesses, incurable illnesses, terminal illnesses. So infertility is just one of those conditions that are quite disheartening. And we have to accept that it's one of those conditions where we've got to be bearers of bad news. The patients have always dealt with bad news for decades and for generations. And I think they can still deal with any other situation of bad news. That's just my contribution. Thank you, Dr. Mahapa.
Thank you very much, Dr. Mshuri. I like it because what you brought in is the deficiency in the medical training, that there's not enough anthropology in the medical training. It's only Eurocentric. We don't think there's anything that came Africans, but Africans, if we can bring anthropology into medical training and understand that different cultures use different things, like for example, the Islamic, they've got virginity test and other things is allowed. And even the legislation that you talk about, they allow that. But if we can try to do virginity test in an African in South Africa, they'll say is gender-based violence or what. But there's religions that do it in the same country is not regarded as gender-based violence. But that's need to go much political. I see here Tomu Charles Mtswana. Mna moholo tse ba ditaba tsa ka mphatlhelo. Mna Tate Mtswana ishita phatla wa hlola banna. What do you say? He doesn't unmute. Tate Monare, the closing remark about this, and then we can close.
You know, I think I'm more inclined to agree with the last speaker, almost 100% with him. The thing is that, truth be told, is that times have moved, and as they have moved, we cannot, you know, keep ourselves at. And I also like the comment that he says that we are bearers of bad news, and it is so true that we probably are faced sometimes with worse cases than infertility, you know, with imminent death or imminent disability, and that might be unbearable to a recipient and to the relatives of this recipient, and we are not gods. It is true, we are not gods, and because we're not gods, we should be open with our patients and tell them about our limitations, which brings me back to, you know, 10 years from now, 20 years from now, there probably might be cloning. And when cloning does come, then this issue will disappear, because then technology would then have addressed that problem. But at the present moment, our technology, there are certain cases that it can address, and if it can't, we should just be open and say, listen, this is where it ends with me. You're welcome to go and see whether you can seek assistance from other colleagues. But as for me, my knowledge and my capabilities end at this point. And I definitely agree, I 100% agree with the last speaker, you know, and it is also true that the patients move around, you know, as long as their problem is not fully addressed, as long as they have not achieved that for which they came, that assistance for which they came to ask from you, and they will go to somebody else and seek assistance. And, you know, and it might not be somebody whose thoughts and whose thinking processes and thought processes are the same as ours or in tandem with ours. And we might find ourselves in a situation where we might end up being sued for dishonesty. Put it as non-disclosure, but it would still be dishonesty.
Thank you very much, Dr. Mana. Ladies and gentlemen, thank you very much. This is the little I wanted to say. I would like to thank all those who participated, more especially Dr. Manare. Dr. Manare, I said, is a urologist in Polokwane. Actually, he's the first Black urologist in this town. Since I came to say, I'm only urologist I know Manare. Thank you, Dr. Manare. Thanks, everybody.
Thank you so much. And thanks for the webinar. I really enjoyed it. Thank you so much.
Sure.